Professor of Medical Physics in the School of Physics in Sydney Uni. It's the Ministry of Health. I'm not anymore Ministry of Health. I have been the Ministry of Health funded post for 6 years. I'm involved in Paul Keel's the leader of the MR-Linac project, and I've given a few talks on under this. Oh, we've lost the top of it, but on this title. Towards biologically guided adaptive radiotherapy using hybrid imaging and treatment delivery systems. In the UK, I recently gave one for the Royal Society of Medicine that had a Future of Medicine 2025, which doesn't seem to me as though it's looking forward very far, but I was asked to talk on that. When Per mentioned this meeting, he asked me what topics I could talk on. I offered a few, including the data mining, multi-centre data mining and radiation oncology project that I've started in New South Wales and growing across Australia. If anybody's interested in that, come and talk to me afterwards. We want more and more centres involved. But they went for this, I guess, because Electa have a clear interest in trying to raise the profile of MR-Linacs, and I'll talk about that. I've got Paul on as a joint author, and Paul's in the audience, so he might heckle. There's a lot of slides from Paul, but really this is on behalf, as a lot of these presentations are, the whole Australian MR-Linac project. So disclosures, I've put up Paul's disclosures, which are patents, variant and standard imaging licenses, and involvement in commercial ownership. And my own are, and commercial grants for Varian, Paul and Phillips. My own are licenses from Electa and PTW, and commercial grants from Electa and PTW. Largely the Electa ones are in Leeds, but I'm still involved in Leeds, and they've continued on to a certain extent. With my Ministry of Health hat on, I'm vendor neutral, of course. Okay, background to this topic. The current standard radiotherapy paradigm, and I don't need to explain that to radiation oncologists, physicists and RTs who are here, but of course is anatomical imaging for treatment planning with input from functional imaging, delivery with integrated or hybrid systems, where the imaging, of course, is CT, i.e. cone beam CT. Image guidance based largely on geometric anatomic targeting and closely conformal delivery, and we do a pretty good job on that. Image guidance has grown hugely from when it started in the late 90s to within a 10-year span being basically 100% of centres. That's a US survey in 2010. Or going up to 2010, but that's essentially a very rapid growth, and of course we all know about image guidance. So some current cutting-edge technical delivery developments, of course, as you all know, image-guided adaptive motion management as part of that, and the adaptive is on geometric and anatomic targeting. So that's the kind of background as to where we are, and we're trying to increase the target dose and or minimize the organ risk dose, so overall increase the therapeutic ratio. And of course it's based on the thing that we've been doing as physicists and engineers and RTs and radiation oncologists from when radiotherapy began, the well-established or well-used concept of using dose distribution or dose volume characterization as a surrogate for improved treatment. We think if we can give a better dose distribution, we're giving a better treatment. And I kind of wrote that almost as an exam question and said discuss, because there's a huge discussion around that. So if we're doing really well, why do we need better adaptive technology? Because tumours are complex and they're changing situations, and each advance we get, we need to have other advances to take advantage of those previous ones. And there's lots of evidence around, these Quantec things, lots of evidence around of clinical benefit of better targeting technology, adaptive targeting technology. Less normal tissue and lower normal tissue dose equals less toxicity. Now you sit with the Ministry of Health people and they keep saying we buy all this new technology stuff and our outcomes aren't any better, where they think of outcomes as survival. But of course reduced toxicity and quality of life is equally as important. So geometric accuracy, improving our targeting is clearly important. Motion is one of the biggest areas in the dosimetry chain. This is a recent paper by Emma Colville working with Paul's group in the Green Journal this year, where they compared motion corrected against non-motion corrected and just looking at the improvement of the dose distribution and hence the assumption is of the therapeutic ratio. So the reds are non-compensated for motion, where up to 20% of points in the dose distribution are not meeting 2% 2 millimeter requirements, and the blues are corrected. And they've compared across 4 different types of motion correction: robotic tracking, gimbal tracking, the Vero, MLC tracking, Paul's work, and couch tracking. So there's lots of evidence around about that. So why do we want to move into new image-based, at the point of treatment, adaptive therapy? Well, the limitations of CT, as we know, I mean, there are pros and cons, of course. We've got good geometry with CT, and we've got the basis of planning, but we have not got good resolution across soft tissues. So highly conformal radiotherapy, hyperfractionated, dose-escalated radiotherapy, we need to think about higher resolution imaging. And we begin to need to think about requirements for biological targeting, because if we start to use MRI imaging, we can think about that. So parametric and functional image guided, so biological targeting. So we can begin to move into adaptive biological targeting, taking into account the biology and the changes of biology of the tumours in the overall tumour and subvolumes of that. We can begin to monitor treatment response as the treatment goes on, and so we can begin to personalise medicine using image-based biomarkers. So the idea, of course, is to go towards MR and PET-CT as input and MR as in-room image guidance. So essentially, I'm going to look at a couple of things about that, and then really do a really brief overview of the of the technology, having thought about the rationale. So our original goals in adaptive radiotherapy were to keep treatment delivery on track to maintain the original intent, essentially freezing the target in 4-dimensional space, delivering a gold standard treatment, and adapting in a relatively minor way for minor changes or more significant replans, inserting an interruption when things went significantly out of tolerance. And the essential approach was that all patients for a particular indication got the same or get the same prescription. The potential now is that recognizing that the target alters in all 4 dimensions, but alters not just geometrically but biologically as it responds to the treatment, we can change the paradigm. We can adapt and adjust the treatment in immediate response to what we see each day, so daily adaptation. And we're doing that with CT, cone beam CT, based adaptive, geometrically or anatomically based. But given the tumours are complex biological systems, we can characterize those on a case-by-case basis and begin to adapt biologically if we can get appropriate imaging. So we can titrate the dose and fractionation according to observed responsiveness and begin to change the dose prescription and distribution as we go on. So it's not one size fits all anymore. So why MRI-guided radiotherapy instead of, so why an MR-Linac, for example, rather than a CT-Linac hybrid? First of all, why not? And this is, I like the way that Paul usually asks this. So there are lots of other solutions for image guidance around, and they are pretty good. But we've just seen there are limitations on CT-based ones in terms of soft tissue resolution and image resolution. Another big problem is that MRI and Linacs are both complex systems, and so you end up with a doubly complex system, and that complexity is significant. They produce effects on each other in terms of the RF from the Linac can affect the MR imaging, the mag field from the MRI can affect the Linac. So you have to optimize the design to make them magnetically independent and do lots of interesting things, interesting physics there. There is MRI distortion. The mag fields can affect the dissymmetry, and so one has to cope with that. And the hybrid cost is significant. Electa might correct me, but hand-wavingly, you can buy an MR Linac for the same as 2 or 3 standard Linacs. Now, I was going to start off by saying that's expensive, but Arjun then said 30 or 40 million for some facility he wanted. So actually, I'm going to tell you that MR Linacs are cheap. You can buy Arjun's system for probably 5 or 6 MR Linacs at the current prices. So why MRI? The advantages of MRI Linacs. MR is recognized, of course, in the imaging as input, as the ultimate in imaging for guidance, volumetric anatomic information at time, superb soft tissue resolution, no implanted markers and no imaging dose. And you've got the physiological targeting potential if you want to move towards biological targeting. You're imaging the target, not a surrogate. So you're imaging directly what you want to see. And of course, you're getting superb images in real time as you treat. You can image as you treat. Currently, we can image before treatment, we can image after treatment, but we have no means of imaging during treatment. So that's your image while you actually treat. So you're not seeing what's happening while you actually treat. Whereas our potential with MRI guidance is imaging during the radiotherapy itself. So real-time image guided, and the potential for anatomic and biological imaging and real-time motion tracking. So let's really quickly look at the current systems that are around, and I'm going to look at 4 systems. The Utrecht development, which has turned into the almost clinical Elekta MR Linac. The ViewRay, which is already clinical, which is not an MR Linac, of course, it's MR Cobalt 60. University of Alberta development, and then last of all, look at some of our own Australian research MR Linac work or development. So the ViewRay system first. I've done that first because it was first to market and first to clinical use. The ViewRay system goes back to Cobalt 60 for radiotherapy delivery, and immediately, as workers in the field, we begin to kind of feel a little bit twitchy about that. But they've got round some of the issues or the old issues that we think of in Cobalt 60 by using 3 cobalt heads at 120 degrees to each other, dual-focused MLC, so trying to control the penumbra. But still, there are a number of planning studies out in the literature on the ViewRay system, and where you expect they'd fall down, small targets or small things you're trying to spare within a target, they do fall down. It's a low field strength magnet. It got FDA approval in 2012 and treated its first patient in 2014. It's installed currently at 6 centres and probably 4 working clinically, including 1 recently in Korea. And there's a fair bit of stuff now growing in the literature and on the website, or on the web on that. It's got a fast Monte Carlo dose calculation. Will provide you with MRT, on-couch adaptive radiotherapy, fast planning, 9-field MRT plan re-optimized in 30 seconds. You clearly want a fast workflow. The patient's on the bed. You want to, if you're going to change plans daily. In use for a wide range of treatment sites. The next slide will show that. And when you go on their website now, they are talking about the development of an MR Linac. So moving on from the MR Cobalt 60 towards an MR Linac. And that's a summary of the use at Washington Uni in St. Louis. They've got experience in 20 to 30 body sites. The biggest use ones are bladder, prostate, and breast, but used in a whole range of other sites. I've been into that centre and seen the online imaging, and it is really impressive. Okay, the University of Utrecht one, so kind of fits in with the Elekta theme. The concept was first presented in 2000, and there's been a whole long development of really interesting pre-studies in the University of Utrecht, using initially a benchtop system, a kind of proof of concept system, and it's gone through 4 generations from that to install preclinical prototypes with a rotating gantry and MLC, and now to clinical systems, and I've got a couple of slides later on that. It's a 1.5 T magnet, MLC tracking. The radiotherapy beam is transverse to the direction of the magnetic field, and I'll come back to that. And there have been a whole host of preliminary imaging and dosimetry studies in the literature now and in conferences to underpin the feasibility of that. So it's gone through 4 generations, so proof of concept, rotating gantry and MLC, preclinical prototype, and clinical systems. And that's now labelled with Elekta because it's the basis of the joint collaboration between Philips on the imaging side and Elekta on the radiation side to produce the current clinically available or consortium available MR Linac. And that consortium is called the Atlantic Consortium. Lots of information on the Elekta website about that. And they've got together a range of centres for coordinated clinical introduction to evaluate the feasibility and the role of MR-Linacs in a whole range of treatment sites. So the centres are listed there. They include Sunnybrook, so any medics who have questions about why a medic would want to have an MRI Linac can direct them not at me, but at Arjun at the end. That's from the website, and it says the rationale of the Atlantic Consortium is to discover and enhance, that's probably too small for you to read the back, to discover and enhance new technologies that focus on improving and prolonging people's lives. I think actually that's an elector statement rather than a specifically Atlantic Consortium statement. And that clinical consortium has a clinical steering committee with leads per institute. It's looking at 9 main tumour sites after a group of experts got together to think what sites they should look at, where they might have the most bang for the buck from NR Linac use. They have disease site coordinators divided over the institutes. There was, for example, very recently in June 2016 in the Green Journal, a first review out of this consortium looking at a systematic review of MRI-guided adaptive radiotherapy for prostate. That's quite a nice paper, 150 references in there. They have a data management task force looking at IT, legal, governance and data collection issues, a methodology advisory board and a range of technical working groups. They're looking at the technology, the workflows. The first area they've looked at in humans, or looking at in humans, is bone mets, so a relatively straightforward site to look at first. But they have plans for a broad range of studies on clinical introduction and value proposition, evaluation of the advantage of MR Linacs and what the role should be. Will every centre have an MR Linac? Certainly not in the early days, but watch that space, I think. Third system, University of Alberta MR Linac system. They have for a long time been doing developmental work as well under Faloni. 6MV Linac, half T superconducting magnet, in line now, i.e. the radiation beam is in line with the magnetic field, and that means that it's coming down the bore of the magnetic field, so you either have to rotate the patient or rotate the system, and the University of Alberta have gone to rotate the system, and I'll come back to that in a moment. They've gone through 3 phases as well, and are now also beginning to be associated with the commercial development, which you can see on the website. That's skipped. I skipped those 2 slides. This was some slides that Justin Turpin gave me from a lecture, which should have gone before the University of Alberta one, but basically the clinical MR Linac, which is being rolled out to that consortium now, from concept to realisation. So concept drawings of the Linac itself and the MLC system, rotating MLC system, installation at MD Anderson, which was the first one in, I believe, the magnet arriving, and then the ring with the magnet going in and beginning to look like the joined up system. There are other MR Linac systems around. Siemens has talked about a benchtop system, and Princess Margaret has an MR on rails. If you think back to the early days of CT in the room, CT on rails, where the so the Linac's here, that's the Linac couch, and the patient can, on the Linac couch, go into the donut of the MR and then come back out into the Linac. So in the same room, but not integrated in the same way. And then lastly, coming to the Australian MR Linac program, so led by Paul. The system's installed at the at the Liverpool Hospital, Ingham Institute, and the aims are as a research system at the moment, real-time MRI, cancer imaging and radiation targeting, exploring the clinical benefit of physiological targeting, assess the synergies with combined modality therapies, and evaluate inline and transfers. I mentioned those with individual systems. So the system can be set up with the radiation beam going down the bore of the magnet or going down between the 2 sides of the magnet. So in line with the magnetic field or transverse to the magnetic field. And there are pros and cons of both. And the downside, you might think, as practicing people in radiation oncology for the inline is you've got to rotate the patient. And that usually gets people slightly worried, but there are methods to do that. And if we're going to fast image and fast register and fast replan anyway for adaptive, then you can take account of changes and you can think about a workflow and a process for that. But there are some significant advantages for inline as opposed to transverse or perpendicular. And one of the rationales of this program is to, as a research approach, is to look at the advantages and disadvantages to try and establish the role of that. Now you can see I'm trying to save time. I'm now trying to get 3 slides on one. The inline design needs some new thinking, as I said, on patient positioning and rotating the patient or rotating the system, as the University of Alberta has gone for. There are some advantages for a number of uses for rotating patients in terms of cost-effective radiotherapy. That's Paul's NanoX project, some particle therapy applications, synchrotron microbeam therapy, and so on. So actually this research will spin off into other areas. And so one of the areas of research is to quantify patient acceptance of rotation, quantify the uncertainties, quantify workflows, look at how to deal with that. So the Australian MR-Linac timetable, initially the Linac and MLC went in, and then a kind of preliminary imaging system, which was an ex-clinical Siemens scanner to do proof of concept while we waited for the designed specific adjuvant magnet that has now been installed for the system as a whole, and clearly working towards a future prototype. But hand-wavy timescale, you can ask that Paul that at the end. Just preliminary performance and imaging results. The first full paper has been published just recently in Medical Physics by Gary Liney et al. And this, some of you may remember that, or may have seen this. These were the first MRI Linac images from Utrecht, where they took a pork chop and looked at the image without radiation and with radiation, and basically showed that their design was optimized so that the two didn't affect each other. Gary decided, as it was an Australian system, to use a kangaroo steak, and basically showed the same thing, and that's been published. Electa have recently put something out. I got this from Kevin Brown, where clearly trying to think of a clinically relevant target. They've imaged an egg inside a pineapple. So, I think that's meant to be a prostate, but anyway. And that again is without radiation to with radiation on the clinical prototype. So essentially, the Linac operation is not affecting the images, and that's the bottom line that you want. There is an extensive research program around this with multiple Australian centres involved, looking at optimization of magnets, optimization of detectors, Monte Carlo simulations of beams with and without magnetic field, optimization of the design of Linac components, and their optimization in terms of magnetic decoupling, and then lots of things around the way this could be used with patients, including for the inline design, a rotating patient system, and testing the acceptability of that. So very rapidly through some applications and new opportunities. We've said that it's the superb normal tissue imaging and fantastic soft tissue resolution that's good. There are beginning to be a growing number of papers looking at MRI-guided radiotherapy in terms of adaptation and motion management, and that lists just 3, including that systematic review that I mentioned. And the next few slides give a couple of image examples from that. So Acharya have looked at a range of patients for abdominopelvic malignancies, and basically come out with quite a large fraction needed optimization with the basis being MRI imaging. And that's one picture from their work where not seeing that in small bowel, but as opposed to seeing it and reoptimizing, can radically change, can significantly change the small bowel dose in those patients. Various people, including Paul's group, have been looking at tracking radiotherapy. And so if you've got, again, really good imaging, really good soft tissue resolution, you can delineate your targets for tracking really well and track on the basis of that. So Paul's demonstrated tracking already on X-ray-based imaging. So clearly, it's a small step from that to MRI-guided tracking. I said that ViewRay have looked at a really wide range of sites, and this is from some of ViewRay's published work. And I'm not going to go through that in detail. I'm running out of time already, and I've already pointed out that spread of clinical practice there. Some physiological examples. There are now a growing range of papers in the literature and in the conference literature on physiological uses of MRI at the point of treatment for tracking hilar lymph nodes, that's Utrecht, lymph nodes in breast cancer patients, repeated ADC measurements with time to look at response to treatment and then modify on the basis of that, so begin to personalize the way that the treatment is modified as you go on. So examples of imaging and targeting breast lymph nodes, seeing those clearly from Utrecht. Example of treating lymph nodes without any significant dose to the esophagus, again for Utrecht. This is the Yang example of sequences through time, so across fractions of ADC, looking at the response and allowing you to adapt in terms of responsiveness and biological response to treatment. And another from Paul's group of target tracking, real-time imaging and target tracking. And jumping on one to Utrecht's work on 4D MRI and deformable maps of image registration and tracking, the basis of tracking on the back of that. And in addition, Utrecht have done some work on online verification, so online-based, MRI-based dose reconstruction, looking at dose accumulation with time through the treatment as a real-time verification. So a whole range of possibilities that are opened up. In summary, we are going to we'll have to change workflows and processes from MR-Sim and PET-CT up front, biological input to planning, and then biological verification, adaptation, and targeting. New workflows from MR-Sim to MR-Linac, new requirements on patient and equipment management. Clearly, you're going to need rapid deformation between the pre-planning image, the pre-treatment images and the daily treatment images, rapid replanning, modification or re-optimization, and rapid software-based QA, and all that has to occur within a very few minutes, patients on the bed, done on a daily basis. There will be new risks to manage, both in terms of equipment and patient, and clearly, although that's a diagnostic MR scanner, some clear safety things. We will have to start controlling, of course, treatment rooms in a very different way to the way we control them now. They'll need to be controlled for radiation, but also in the way we control MRI rooms. And so this is Paul's prediction, going back to that 2010 image-guided survey. If we shift the timescale, we're at 2016 now. In 10 years' time, it's Paul's prediction that everywhere will be using MR-Linacs. And in fact, if you go on the websites for ViewRay and Elekta, they are saying that by 2019, so that's just 3 years away, they'll have sold 100 units. Now you think of the hand-wavy price that I kind of indicated on an MR-Linac, and 100 units is a lot of money in the next 3 years. And there are other companies in the wings as well. So cost, radiotherapy we're saying is cost effective. This Artoon reference is the Lancet Oncology Commission, published in 2015. IGRT is extremely cost effective. Trogan Ratat says for standard IGRT, $140 per quali. We know that managing side effects and treatment failures are expensive, and one of the things that Toon et al., which includes our own beloved Michael, whose name is gone? Barton, yes, thank you. Conclude of their review of radiotherapy provision globally that our results provide compelling evidence that investment in radiotherapy not only enables treatment of large numbers of cancer cases to save lives, but also brings positive economic benefits. So I add on Paul's rider to that, taking the broader context of healthcare, and I think that means, compared to what Arjun just talked about, MR-Linacs will be a good investment. So in summary, MR-Linacs are soon to be clinical, or just about are clinical, if we think about the beginning centres in the Electa consortium. MR Cobalt 60 is already clinical through the ViewRay system. MRI can provide real 4D anatomy, daily real-time adaptation during beam delivery. The potential for anatomic and biological targeting, so beginning to have physiological and biological targeting, promising better outcomes, but of course need clear evaluation and clear testing of cost effectiveness and cost benefits. The relative cost, I'm saying it's likely to fall, but I think we would throw that back to the manufacturers. We know what the cost of radiotherapy technology is and how it continues to grow, but in real terms, it's probably fallen. It requires a whole set of complex procedures and workflows, and all those need to be evaluated really well and with strong recommendations around how to run that in the most efficient and effective manner. And as part of that evaluation, to increasingly look at the number of applicable treatment sites. Combined with other developments, it's leading to new adaptive radiotherapy paradigms and potentially opens up new tumour sites for radiotherapy. So acknowledgements to Paul, who's the co-author and visionary. He's ringed there. Lots of people in the MR-Linac team, lots of people in other places who've given me slides for this. But although I say Paul's the visionary, of course, the real visionaries are the ones who don't look at the camera. They're the ones, in which I include myself, who look off to the far distant, wonderful future. Or maybe they're just wondering when the coffee's due. So I know I should stop now because you've got more drinks to come, and you're probably wondering when the more drinks will come. So thank you for listening. Well, the MR will do some of that. The problem with the PET at the moment is the resolution, of course. I think you add yet a further set of complexities, so you'd have to control the room for radiation, MR, and now radioactivity as well. So, yeah. The experience will grow. I mean, look, people said the same thing when we put flat panel images on and other systems on Linacs, and they've been reasonably robust. And I think it's a question of, to a certain extent, suck it and see. But the ViewRays have been running for a while now. Okay, they're in. It's a lower field strength system. It's less stressed. The Utrecht systems have had a lot of hammer on physics and testing and things in their various guises over years. So I think that's something that probably we will learn with experience. It's hard to see how much functional imaging you're going to do with the ViewRay at 0.35. 0.5 is really on the edge, but I think by the time you get to 1.5, you can clearly do some appropriate biological things. The higher you go, the better, of course. I mean, there are a lot of areas of these systems that we have things well in place for standard machines and standard image guidance that completely new processes and workflows are going to have to be worked out, including that.
All right. Thanks a lot, David. Excellent.